Hey, Nicole. You look pretty close. Yeah, what's up? Hmm. Yeah, that's what I heard. Okay. Thanks. Okay. Well, yeah, yeah. Hmm. Yep. Yeah. Oh dear. Gosh. Okay. Yikes. All right. Nope. No worries. Can I'll call you in like a little bit and I'll catch up with you about that. Okay. Perfect. Sounds good. Thanks. Bye.
Hello.
Hey, Nina, how are you?
Hi, how are you, Katie?
Good. Can you hear me okay?
Perfectly. And I
All
can
right.
see your
Great.
stuff.
Fantastic.
This is perfect. So glad that you're doing this. Thank you.
Yeah, my pleasure. My pleasure.
That's good to be. Thank you.
It's a bummer we couldn't
And
do
I
it in
have your
person. I'm
bio.
sorry you couldn't make the drive up there. That sounds be a fun day to be in
Oh,
Ann
no
Arbor.
problem at all. Yeah, I know the fall has been really quite beautiful.
It is gorgeous.
Yes, yeah, it's really great. Um, yeah, cool. How's the family?
Oh my gosh. So big. Grace is 10, if you can believe
What?
it. I know. I know.
Gosh.
Been 10 years since I've been in fellowship, which is kind of
Yeah, I was just thinking that today, actually.
yeah.
Yeah.
So she's good. And then my next is Emmett, and because I was, of course,
Yes,
pregnant with him when I was there too.
I
He's
remember.
9. And then we have our trailer, which is Annie. Annie's 5. So yeah,
Aw,
they're good. They're great kids. We're really lucky, but it's been so busy. So,
I can only
everybody needs a
imagine.
ride everywhere. Everybody needs this.
Yes,
How about you
exactly.
guys? You're all good?
Yeah, we're doing well. Thanks. Can't complain. Yeah.
Good.
Different kinds of busy, but good.
Yeah, understood.
Yeah. 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 No, it's good.
So you guys have, let's see, 1, 2, 3, 4, 5, 6, 6 fellows or 7?
7 fellows.
7, 7. Okay,
Yeah.
gotcha.
7 fellows. Yeah. And we just finished our recruitment for next year.
Oh boy. I
I mean,
was
finished
gonna
the
ask
interviews.
about
The
that.
season's match hasn't happened yet, but we finished the interviews.
Yeah, yeah. That's a big deal. Goodness.
Yeah. Yeah.
That's
Very.
so fun. I can't believe that's already come and gone already. That's
No, I know. It happened so quick.
yeah. Well, it's stressful, but then hopefully better afterward.
Yes. Yeah. No, thank you. It gets really busy, but then it slows down. Oh, and I see a lot of our fellows are joining. So,
Oh, good.
right. So Katie, we'll just give it maybe another minute or so as people file
Yeah,
in.
of course. Of
All
course.
right, great.
Just make sure my
Okay, looks like I'm just counting squares here. Okay, well, we'll go ahead and get started. So everyone, I'd like to introduce you to Dr. Katie Williams. She did her medical school at the Royal College of Surgeons in Dublin, Ireland, her residency in internal medicine at the Mayo Clinic. And then we were lucky enough to have her join us here at U of M for her sleep medicine fellowship. We were just saying a decade ago now, so time moves by quickly. And then after that, she did a pulmonary medicine fellowship at the Mayo Clinic in Scottsdale, Arizona. Since 2020, she has been the ProMedica Sleep Medicine Director. We like to affectionately describe the sleep center there as U of M South. So she's spearheading the efforts there. Katie, we are thrilled to have you back and teach us about sleep medicine practice management. So I will turn it over to you.
My pleasure. Thank you so much. All right, so we'll go ahead and get started. Certainly this presentation is meant to be very informal in terms of the layout. So if you guys have any questions, please don't hesitate to stop me and bring something up in between. And then if not, I certainly will have some time at the end to discuss any questions you might have. Okay, so we're going to go through a couple of different things. One, I'll talk about the introduction, who I am, what I've done so far in my career, and then kind of try and put that in perspective for practice types, the organization of clinical practice, and then the opposite side, which is more kind of the lab organization, which invariably a lot of people will be involved in, and then growth potential for anyone and all, and then final tips and takeaways. So to be perfectly honest with you, I have not given this talk. This is a whole new slide deck, so you guys get to be the first to discuss this, but certainly I've been in practice for now more than certainly almost 5 years as a leadership role, and then nearly 7 in general in clinical practice outside of fellowship. But when talking about the organization of sleep management in both the clinical and the lab side, it's quite a big task to talk about everything, but I certainly want to talk about how I have approached it so far. So this is kind of limited in my perspective, but then I've been able to kind of stand on the shoulders of giants, if you will, in terms of other programs that I've been involved in. So I've gotten a bird's eye view of how much growth and how much potential each practice has had over decades of practice. So I'm very, very lucky in that regard, but I want to make sure you know that this is kind of my perspective. Dr. Shelgakar gave my educational background and my professional credentials in terms of what I've been through so far. So hopefully that'll be helpful to you, but know that certainly there are lots of different perspectives on how to form your career, how to go through your career in sleep medicine. So we'll start with the first agenda item, which is the practice types. So as a fellow, you certainly may or may not have your life planned out. You might have a 5-year plan, 10-year plan. You may not have a plan, and that's all okay. Certainly want to make sure that you know that everybody's been through that before. Personally, I knew I wanted to come back to Toledo. I'm from Toledo. I grew up here. My parents are here. We have, my husband and I are outnumbered in terms of kids, so we figured we need extra help, and so we came back here. And as far as a academic versus a community practice, that's often a big choice to make, whether you, as a person, operate very well in either an academic center or a community center, or a little bit of both. But that is such an important fork in the road, if you will, up front in your career to make that decision. So when making your choice in terms of your career, it's never final, but certainly when you get into a period of time and you want to dedicate your life to your work, it's good to know that you're going to start in a position that you can grow into. So let's talk about types of sleep practices. And I think we're going to get into more detail and a little bit into the weeds on some of this stuff. There are some practice providers who just operate better as a solo practitioner, and that's fine, but you need to identify that in yourself before you potentially either join a group or go solo. Solo providers and, are more connected than they ever have been. Used to be solo, you'd go out and then maybe not get to, interact with any other practitioners or any other people, 25, 30 years ago, except for meetings or, if you were out to a conference. So now, of course, as a solo practitioner, you can have a lot more interaction, through online meetings or local groups. But if you are more of a solo practice, provider, that might be something to think about when choosing versus a group. We are very lucky and affectionately known as U of M South. We have multiple sleep-only physicians in my group. Almost all have rotated through U of M. And so at some point, whether it's fellowship or as an attending. And so our group in itself is quite cohesive because we all have a very similar practice style. Okay. And then comes the decision on independent versus employed versus locum. I've got a couple of friends who locum just a couple of weeks a year. They travel, they go, they are employed very minimally, and then they come back. And that's their happy place. They enjoy travel. They enjoy being, just employed a couple weeks a year, which sounds like a great idea. But financially, it works for them. And then again, whether or not if you're going to be like maybe a solo practicing provider in a independent firm or independent practice versus an employed, group setting like ProMedica is for us. There are also solo practices. There's a couple of practices that we interact with providers up north in Michigan they have their own solo office and they're not necessarily affiliated with a sleep lab, but of course are credentialed and read at independent labs. And certainly that's not our current situation here. If I were to describe myself, I would say I'm a group practice employed by ProMedica that is sleep lab affiliated, and certainly have quite a few in our group. We'll talk to that. And then the final piece of that is that we also have APPs, and I know that of course U of M has them as well, and how you integrate APPs or advanced practitioners into your practice as well. So more questions. I mean, it certainly feels like through fellowship, you're focusing on the details, you're focusing on the content, which is really important. But then there's this big onslaught of questions and how are you going to fit yourself into a practice that makes it, I guess I should rephrase it, it makes or allows you to focus on patients and allows you to focus on what you enjoy doing, as opposed to a continued rub every day about, do you really enjoy teaching? Are you at an institution? I mean, I love all of our, everybody has to be a fellow, everybody has to be a resident, but not everybody is a great teacher. And so that is one thing that you need to identify in yourself is, are you somebody who enjoys teaching? And maybe you do, but you don't enjoy teaching nursing students or residents or fellow. You can teach, but maybe it's a different type of teaching. So you need to identify that. Do you want to do research? Are you an academic? Do you want that to be part of your practice? Do you have administrative prowess? Do you like to be a leader? Do you enjoy being in leadership positions? I don't know, for all of those who have ever done like a chief year, it is my favorite attending always says you're recovering chief, not ever anything else. And so you know that being in middle management can be tough, and certainly that can be part of your job. But if you flourish and you enjoy it, it can certainly be a nice part and a nice addition to your practice. Do you have scheduling constraints? Do you have family members you have to take care of? Do you have other commitments other than medicine that you need to make sure that you can work around? All those things are helpful to know up front when you're building your practice, and of course may change over time. Specifically for me, I did this pulmonary fellowship, and I'm more of a hybrid practice provider, meaning a lot of my practice is outpatient, but I do round inpatient and I round on the weekends occasionally as well. So my schedule has to be flexible for that. I do procedures, PTs, all of that kind of comes into one. And so I enjoy it. That's my favorite part of my job, is that I have that variability, but certainly my practice has been built around that in terms of my schedule. Legal risk, this is more kind of the decision when you're going on solo practice versus group practice versus having APPs. That's something that we'll kind of get into, but not necessarily the focus, but something to consider. Location. I mean, everybody wants to know where they want to work, but depending on the local need for a sleep provider, you may decide, hey, this place is out in California, Florida, wherever. This might be the market might be saturated. You may not survive as a provider there. You might not get enough referrals. Those kind of things need to be looked at ahead of time. And then also whether or not you want to integrate telemedicine, of course, into your practice, which is, of course, a huge growth in the last, really 5 years since COVID, certainly, but even more so since the last 15 years. All right, so I'm going to take a quick break because we're going to transition into more kind of the nitty-gritty details, but it's a lot to consider. It's a lot to think about. Does anybody have any questions so far? And if not, I'll give you like 10 seconds and then we can kind of move on to the next section of my talk here.
What resources do you recommend to find opportunities in like sleep locums? Because I've never heard of that before. It's pretty interesting.
Oh, yeah, absolutely. Great question. So, I mean, ASM, the website has certainly some availability out there. You'll have certain practices, like really Facebook. It's like some Facebook groups will say, my provider, I'm a solo provider, I'm going on maternity leave, I'm going here. And that's the only thing that I've seen so far. And it's few and far between, and a lot more likely to be sustainable if you do have like a hybrid practice. So say you're like an internal medicine and then pulmonary and sleep. That's been kind of my jam. And so I've been offered quite a bit of it, but I think they somehow got my email or cell phone and I've been tagged. So that's the only suggestion I have. It's not really, probably not long-term sustainable.
And telemedicine, is that something that's like you could purely do sleep tele? Is that common?
It is going to be more and more common, I'm sure. There have been, I'm just going to try and avoid any bias here, but there have been certain companies that have reached out to me and said, hey, we're looking for a medical director to potentially read home sleep apnea tests for our device. And with that, we're looking for you to do telemedicine in XYZ states. And then of course you get, your state license and go from there. But yeah, there are growing practices that need a sleep medicine doc in rural Alaska or rural wherever that might be able to drop ship a home sleep apnea test to them. And so they need a sleep doc to be able to order it and manage it. And so there has been some, but it's probably not nearly as much as a, brick and mortar type of setup. And I'm happy to help you kind of lead whatever I have. I'm happy to spread if that's something that you guys are interested in. But it's certainly a lot less common, but I think it's probably going to gain some traction.
Thank you.
You got it.
Sorry, I'm looking in the chat. I don't see any questions there.
Thank you. Perfect. I can't see it, so that would be great if you don't mind just stopping me. All right. So clinical practice organization. So give me 1 second. Here we go. All right. We're going to talk about in that all of those options. I'm going to talk about how I got from A to Z and how a lot of maybe my co-workers, my prior fellows, how they've transitioned into their jobs they're at. So your starting point maybe now, maybe this was 3 months ago. You know, some of you might have been able to tune out because you already have a setup, you already know what you're doing, maybe you're going on to a different fellowship. But at some point, you've thought about where you're going to go. And so if you're going to, you know, inherit a practice, somebody's retiring, somebody's moving, and you joined in right at the right time, and you're just inheriting a practice that's completely independent, all set up, ready to go. You might be joining an established practice. You might be starting an independent practice. You might be starting from scratch. Those that are bold, I mean, impressed. That's fantastic. But really hard to set up from scratch unless you have some really, you know, helpful mentors, people who have maybe already done this. And then maybe you are joining a practice that's already established. Maybe they're pulmonologist and they don't have anybody who's sleep trained. That's a huge portion of a lot of the providers that, you know, came through pulmonary critical care, and they had a lot of sleep training, but certainly before sleep fellowship, just were never boarded. And we've got a huge amount of people now with all of this data, right? They have a download, they have everything to evaluate, but some of these providers haven't had as much experience, and they're looking to just kind of offload a bunch of these sleep patients to you. And so you might be starting in a practice that doesn't technically have a sleep practice, but even though they're maybe boarded in or like, you know, have some experience, and it's at a community hospital or maybe even academic practice. We were very lucky in that when I started here, University of Toledo had a sleep fellowship previously, then it kind of went by the wayside. And then, 3 years ago, we're reaccredited and now have another sleep fellow here. And so I got a little bit of an inside view as to how much work that was to restart and make sure all the credentials were appropriate, and how we're involved in that practice as well. So we actually have the UT sleep fellow rotate through our clinic. They read with us. And so as a fellow, it's very nostalgic, and it's helpful to have somebody around because it keeps you up to date for sure. But it is part of our practice in general, and it is a really special one at that. Okay, so again, knowing what you want and where you're going to fit in, this is going to be more of the nitty-gritty details in terms of how you are going to potentially go into one of those previous sections here, one of these 4, maybe 5 if you can, and how you're going to establish your own practice. Because I knew I wanted to do my pulmonary fellowship, and it was going to be after my sleep. And so I have all of my, you know, reading templates. I have all of these things, but I had no idea where they were going to go eventually because I wasn't quite sure that I was going to end up here. And so having these things and knowing what you are going to need when you eventually go out into your own practice, whether that's a group or single, I think you guys need to start thinking about how you're going to keep this data and how you're going to potentially transition it. Because I will say it was there's no doubt in my mind that all of us in our group here, you know, refer to a fair amount of the templates and things that we used at U of M because it's part of our practice, and that's how you learn, and that's how it's like a safety blanket in how you practice, because you know you're not going to miss something when you have something documented necessarily. So we're going to get into that right now, and this is the clinical side, and then I'll talk about the lab management side here. So clinical practice, you've got a large portion of what you're going to do is dealing with your electronic medical record, or the EMR. So as previously mentioned, note templates. So this is only the clinical side. This is even getting into the lab, but the clinical side of things, you're going to, as a fellow, come into contact with a lot of different providers that document differently. And no matter how you slice it, you're going to have a, you know, pulmonologist who has a different slant than a neurologist, or a different than ENT. And so your templates might look different and might be applicable to your independent practice, but something that you feel comfortable that you can sit in with a patient, look them in the face, and then also document at the same time. And however that works, however you decide to go about that in the future, whether you include a scribe or you're going to be doing it yourself, it really makes a difference when you're talking to patients. Patients want you to actually look at them when you're talking to them, right? That's an important part of this process. And if you are typing away or your notes are so detailed that you can't look at them or you can't refer to them in a question, it's going to be really difficult for you to sustain that long term. So I will give you some examples of the notes that I have. A lot of mine are check boxes, but then of course, something to fill in to give more detail to the note, because of course patients can look at your notes now too. So a lot of what you're judged on as a physician is your bedside manner and then your notes too, because it's important to make sure we communicate accurately to patients and to other providers. Of course, also questionnaires. A lot of our, sleep medicine is questionnaires, the Epworth, insomnia, RLS. We've got a lot of questionnaires to fill out. And for us, we're very lucky in that our IT folks are very involved in what we do and certainly willing to help us include, the Epworth and things like that. So we can just have a dot phrase and it populates into our note, which helps us make things a little bit more streamlined. Educational information afterwards, you guys are all very familiar with that, because I know that our template was very similar when I was a fellow 10 years ago, that you can include those in your after visit summary. You can include those, in maybe an after visit MyChart and message. But an important part of billing your note is whether or not you've educated and certainly included that education in your note. And then a huge portion is how you evaluate and how you include and how you document the evaluation of sleep data therapy. So whether that's, PAP machine, whether that's, actigraphy or hypoglossal nerve stimulator data. I mean, there's all these things that you can include. And when you independently review, that changes, of course, your level of billing. And so we have included certainly those in our notes. A lot of us use the snippet function and put it directly in our notes, and then refer to, in our impression that we've independently reviewed and made changes based on data download as well. And so that's a big part of our notes. And I'm sure you'll probably continue to learn that as a fellow as well. And then stakeholder wise. So this is incredibly important, because if you are starting from scratch, this portion alone is going to be a huge part of your individual practice up front. Especially if you are starting from, like maybe a practice that has an EMR, but no templates, no sleep data. And of course, in Epic, it's pretty easy to do so. You can, take a Word document, or you can take a document previously, put it in there, and, voila, there's your template. But if we're talking about other things like order sets, educational information, questionnaires, you're going to potentially need IT's input on that. And so knowing that ahead of time and maybe planning for that in your first few weeks to months is going to be important. Your department chair. So your department chair may not be a sleep provider. You got to make sure that they're aware that you're building your practice. And when you're kind of doing so, things might be slow. Most people are very much aware of that, but something, laying the ground rules down up front. Support staff. I cannot stress this enough. We are incredibly lucky that we have support staff that have been in the sleep field longer, at least from my staff, have been in the sleep field longer than I've been here. They're very familiar. They've seen quite literally everything. They've gotten, they can probably get a download from any machine anywhere, and that's always nice to have. They're familiar with the masks. They're familiar with, sleep problems. That's something that you can't always recruit, can't always have, but knowing somebody would be willing to learn or able to potentially handle those kind of things is really important. And then also any referring, clinicians, building your practice, getting your name out there. it's an easy sell when you have a degree from U of M. I say that everybody takes notice, which is always awesome, but it's really important to make sure you establish yourself early on as a reliable, open clinician. And I think that's a pretty easy thing to do coming from this fellowship. So I took quite a bit out of where, in terms of organization from this document that ASM has. And so I would recommend that if you are building your own practice, making sure you go through this PDF. It's really helpful just to give you some insight as to what you need, how you need to set it up, and how you're going to integrate everything else, including telehealth and those platforms, because sometimes it's easy. Sometimes you walk into a program that it has it all, and other times you'd be surprised what is not there and what's not available. So let me get into my templates, because this might be helpful. Certainly you guys have a wealth of knowledge where you're at. We just have a little bit of a different setup here. Your templates, what I would suggest you have templates for when you leave are just making sure that whatever template you are currently using, if you like it, use it, bring it with you. I don't think, of course, Dr. Shervin and Dr. Sheldon Carr were incredibly generous in saying, like, use what you have, bring it on, make sure that you continue that path and you have good notes, and it'll reflect very, of course, positively with any type of new fellow to have an incredibly succinct, helpful note, helpful note. So clinic notes, post-visit instructions, also thinking about when you're going to a group or building a group, whether the group wants a uniform template versus individualized. Ours are all individualized because we have different needs. Some people are more telemedicine based, some are pulmonary, some are neurology, some internal medicine, some pediatrics. So we don't have a standardized template necessarily for every patient, but certainly you could consider that as a group if you're in the leadership role. This is incredibly tiny. I don't think anybody can see this, but I'm happy to pass it on. This is one of the templates that we use for telemedicine. Yep, go ahead. Oh, maybe it was an accident.
Ron, did you have a question? Doesn't look like it. Katie, go ahead.
Okay.
Oh, sorry. No, I don't have a question.
Oh, okay. And so this is my template. It's I have a lot of, check boxes, asterisks that I can fly through in terms of filling in, and then also being able to give a little bit of a synopsis as to what happened since my last visit, or what happened, this is a new patient, they're presenting for XYZ. And quite a bit of it is filled in before the patient's left, so that I'm not after clinic trying to fill in the gaps. It's mostly, cleaning it up, making it look nice, and then on it goes. So because nobody really wants to stay after clinic to finish their notes, unless it's something that, you had to spend time with the patient and you just had to kind of catch up. But certainly it has to be enough to where you get the information you need and then move on to the next patient. And certainly in clinical practice, and when you're running a pretty busy clinic, it needs to be succinct. Okay, and then templates, again, more details, but certainly important. Shortcuts, drop downs. I really like the drop downs. Those are very helpful. Manual free types are a lot more time intensive, but sometimes give a little bit more of individuality to each note. And when we're talking about, click boxes, so mask interface, I think I took a lot of this from actually the VA. When I rotated there was a lot of click box for certain, really common problems you have with mask interface, epistaxis, airphagia, pressure intolerance. And then I often will give more detail after that, what specifically they're having, so that we can refer to that later. And their sleep schedule too. And where you're using that is mostly in, clinic notes, telephone encounters, medication refills. We can use that in all in and above. And then order sets. So I didn't really delve into this in detail because we had some, but very limited order sets when we started here, or when I started back in 2017. And so a lot of this grew over time, and our IT staff, like I said, are very supportive of adding in certain things that we need. So, having a sleep study, home study order, split night, adult. So this is what we have access to. And then our lab is an open lab. So anyone can order, but of course, then we review the order before it's completed. But the ordering providers that are non-sleep physicians do not have access to MSLT. They don't have, MWT, ASV, IVAPS. They don't have any of that. They have a very limited order set, which they can use, whereas we have a lot more. So that has been very helpful to try and avoid erroneous orders, or maybe they thought they were ordering something that they didn't know. So if they know that they have a home study, a PSG, and a PAP titration, maybe, and I think a split night, that's it. That's all they have access to, which has been very helpful. So a diagnosis list, this is really not something you can take with you, but maybe just keep a list, even like a document. But when you're associating your PSG with OSA or some type of parasomnia, if you can build a list, it goes so much faster when you are clicking and going, so that when you're sitting there with the patient and you're saying, okay, I'm going to order you a PSG, or I'm going to order your PAP titration, that it doesn't take you 30 seconds to do so. It takes you 10 or less. And so it's just more time, a lot faster, a lot more cohesive for the whole visit. The other part of it is that if you are in academics and you're making, you're accurately associating this order with, the right diagnosis code, or after post and you're billing and you say, okay, this patient has idiopathic hypersomnia, this patient has RLS. When you go back in and you need to find all of the patients in your EMR with RLS, it's going to make it a heck of a lot easier to make sure that you have all those, appropriate diagnosis codes. And so for research, for your QI projects, for ASM accreditation, it's all very important. And again, some of these, when you build your list, it's more comprehensive. This is a really old screenshot, but you can kind of see, like, there are some that are CPAP, OSA and CPAP, some that are treatment emergent central sleep apnea. Some of my pulmonary ones got in there too, but it's an incredibly comprehensive list that it makes my job a lot easier. Post-visit education, we have a very large list of things that we can just search function and drop in for patients. We have templates, we have websites, we have handouts for everybody in all reading levels too. So we always will make sure that we have whatever we can do to, create an inclusive environment. And certainly we're learning and we're changing at as much as we can. But I will say that, it's sometimes very overwhelming to be in a visit for 30, 40 minutes, and then you forget what's going on or what you talked about. We have a couple of templates that we hand out. This is one of them. I don't anticipate that you're going to read this, but this is, when you visit my office, you are going to receive a call from, if you get a sleep study, you're going to receive a call from our sleep lab who is going to talk to you about scheduling your sleep study. They're going to do the prior auth. They're going to do all that information, and and they're going to potentially call you back if it's not in network or if it's not approved by your insurance. And then, preparing for your sleep study, what happens after my sleep study. And so that, again, it cuts down on calls to your office. It cuts down on calls or my chart messages too, to give some of this information to your patients. Is just, you want to make sure that, of course, it's updated. If you have something change, we had to do a huge policy change when COVID happened. And so there's things that change and move. You just want to make sure all of this data is, again, accurate, but very helpful. And I'm happy to share any of this information that we have If you are going out on your own, I'm happy to help however I can. So this is kind of more of the leadership side of medicine, and certainly want to talk about this pretty quickly, but outcome monitoring is really important, especially on, the more, it's for everybody. It's important to know how long is it taking for patients to get in. No-show rates. What time of day does most people no-show? That's a thing. Note completion. How long is it taking you to finish your notes? If it's taking you a long time, maybe we need to talk about, how we change things, how you change note template. What can we do to make your job easier and more efficient, as opposed to having you stay, sometimes hours after to make sure that your notes are perfect, because there are ways to make it streamlined. Press Ganey scores, RVUs, those are really independent to your practice and whether you maybe, you might be somebody who's got a certain RVU base that you need to meet every month, or if not, certainly it's good to help your practice in general to know who's doing what and how much. And then who's going to gather that data? A lot of the time it's a practice manager, definitely not me anymore. But it is helpful to have somebody who's familiar with this information to help you grow your practice in a way you want to. So let's talk about that. I mean, ultimately, this is going to be a little bit different for everybody, but we have a virtual meeting every other month with our leadership, our ProMedica leadership, to kind of go over all of those things that we talked about. Our practice manager updates on certain sleep specific topics. We have RVU bases provided as a group, and then they're individually emailed out privately so that everybody, not everybody is on blast as to what happened. Maybe somebody had vacation, somebody had this, and so it's going to change every month. But overall, you just want to try and keep people moving and keep people being efficient, because ultimately that reflects quite heavily on your practice. And then this is kind of the last topic in this section. So hiring advanced practice practitioners. So this is something I learned quite a bit about after I graduated, and certainly very helpful to know. But you've got independent practicing providers that are going to independently bill. Certainly they can see quite a bit more patients because they're billing outside of what you're seeing, but you don't have much interaction with those patients. They may be at, we have a couple of NPs that go out to our, clinics out in Fremont or Defiance, and they have in the past had completely independent practices. They very rarely interacted with us or the overseeing physician. That's become less so now. We have tandem clinics, so they have their own clinic. We have a clinic at the same time. And so if there's a question, my nurse practitioner will just walk into my clinic and just say, hey, can you look at this? What do you need to do? That's been a lot more. I'll go in and see those folks at the same time. I can't say that I personally think that's a safer practice model for some, but it's not always practical. You won't always be able to be there at the same time. So certainly an independent practicing advanced practice or practitioner could be less physician interaction. Joint clinics, sometimes you can do co-billing. That depends on how you interact with your maybe overseeing practice, whether that's like, ProMedica. Sometimes you'll get RVUs built to your name. That's kind of a in the weeds type of discussion, but certainly that's an option. But it's there's a lot more oversight, increased time for the physician to be involved, but definitely positive in that you're more face-to-face time with a physician involvement. And then hiring somebody, oh boy, this is something that I knew nothing about, how to hire somebody, and certainly hiring your coworkers. just other physicians, but APPs. You got to think about whether they're a new grad versus practicing provider, how their schedule is going to look. Are they going to be in the same, same setup as you are? Are they going to see new patients versus return visits, a templated EMR? Are they going to have your same template so everything looks similar? Are they going to do in-person? Are they going to telemedicine? Prior authorizations? Can they do prior auth for you? Or maybe looking at advanced sleep therapies like hypoglossal nerve stimulator. We are very lucky in that our sleep providers or advanced practitioners have been in this field for quite some time. They've got a lot of overlap with pulmonary, so it's tough sometimes to get our sleep only people who are maybe just like in terms of oversight here in this area. We had lots of practitioners in the 1990s that were pulm critical care and sleep, and they did everything. They took care of absolutely everything for that patient, and so that was the expectation, and had been for 2 decades, 3 decades now. And so we're kind of moving away from that. And so it's hard sometimes to separate all of those things, but our nurse practitioners have followed down from that kind of template and that they see both. But now we're seeing a lot more transition to a nurse practitioner who only does sleep or only does pulmonary. And so trying to tease that out is kind of something we're going through quite a bit of right now. And then your support staff. So in general, it falls back to hiring. You never knew that you're involved in hiring after, but who's involved is often an office manager, and you're going to have a scheduler and front desk staff and MAs, LPNs, RNs. Those things are pretty standard, right? You sometimes will even have, if you're joining a group or a hospital service, like that is already set. That might not be something you ever have to deal with. But we are also incredibly lucky, and we followed over the same path as, for U of M. We have a sleep tech that transitioned to more of a day role, and they help coordinate. They do a lot of administrative work in setting up sleep follow-up and new visits. But our goal is to transition them to really a more of like a mask fit, because DMEs aren't doing nearly as much of that, and that we can see the patient, they can see the patient, they can go over mask fit, and we can come in and also do a visit at the same time, and hopefully continue to bill and find ways to really be compensated for the time we spend. Pressure changes, PAP intolerance visits. There's a lot of things that we're looking into to try and help patients be more successful, especially with PAP therapy. So that's that. Any questions? I think I have a couple of things left, and then we'll have some time for questions.
I don't see any hands up or anything in the chat right now.
Perfect. Okay. Stay with me here. I've got like 10 minutes. I think we can probably get through, but lab organization and accreditation. So you've got the sleep lab, and you may have a single site, you may have a multi-lab enterprise. It is going to be really dependent on what kind of practice you walk into. Leadership wise, you may be the facility director. You may have, a lab manager as well that you're interacting with, but a lot of people you're going to be, interacting with on a regular basis from the sleep lab side. Some of this I didn't know coming in. I mean, certainly it's all part of, fellowship training is to kind of know what your job's going to be when you come out. But ASM is very clear in what the facility directors are responsible for. And so it's important to know what you're going to need to do if you are going to jump into this. I was lucky. I had I think I maybe had 6 months before they approached me to be a facility director for one of the labs here. So it was a kind of quick crash course into what I needed to do and what I need to be responsible for. I'm not kind of read through these, but certainly you have to be now, one of the options for facility directors to be a board certified
sleep doc. And so a lot of those are becoming more common now. You have to review the sleep, especially for those who are an open lab, meaning anyone can technically order a sleep study. You have to review the sleep study to assure that there's it's an accurate or an appropriate order. That can be incredibly time consuming, especially if you have, you know, however, like we have like 5,500 sleep orders a year. And so that's not something that you get reimbursed for, right? How are you going to make that included in your time, but not overwhelm your time? And so we've tried to make it streamlined in terms of our affiliated staff and how they're sending it to us and giving us the appropriate information so that we can make the approval process as streamlined as possible, but not miss things and not have an inaccurate study happen. You're responsible for consultations and follow-ups and providing a diagnosis for the patient. You're technically supposed to respond to medical emergencies, or at least have a plan in place to do so. Quality assurance program. Telemedicine is certainly an option, but also in person. Education for the technicians, HIPAA training, ethics, oversight of protocols, calibration of equipment. The list is pretty comprehensive, but very, very helpful. And then the people you keep around you are so important and make your job as a physician, as an educator, as you know, lab manager or you know, whoever it is, it just makes a big difference. Lab managers often have a lot of experience. They help with quality assurance programs and sleep technician scheduling and rescoring and remediation. That list just goes on and on and on. And so having somebody who can do a lot of this for you helps, certainly if you are going to be, you know, a lab director. In our own experience, we have site leads, so we divide the leadership a little bit. We have one person who's in charge of the sleep manager, and then each site has a lead technician. Often that's somebody with more than 5 years of experience. They get a little bit of a pay grade up boost, and then they have regular meetings with us as well. You are going to be, if you are going to be, of course, in part of a lab, you're going to have to go through ASM, or you don't have to, but it is a really positive, you know, it's an important part of a sleep lab. And I would say that coming out of U of M, I would highly recommend that you do ask for ASM accreditation. There's very few labs that that I know of that aren't certainly around this area. We all have to go through it every 5 years, and it is costly, but certainly important to do so. I put in a whole bunch of stuff because there's quite a few. I will say that if you hire a lab manager that does a lot of this, it makes it a heck of a lot easier to kind of go through this process. But you're still going to be involved pretty heavily, though. Like I mentioned, it can be quite costly, but it's important to do so. And then this is my kind of final part here, really, is the growth. So I divided it into two things. One is business and really one is academic. So if we're going to talk about kind of the business side of things, we're talking about going into a practice and really looking before you try to commit is what's the local demand? How do you know that your job is going to be secure 5 years from now? So looking at, you know, what is your referral base? Where are you situated? Where are you going to be commuting to? All of that is important. And if you don't have local demand, can you generate that with telemedicine? If you're in a big state, if you're in Texas, you have a huge base that you could potentially transition to. If you are in, you know, Rhode Island, maybe not. And it might be, you know, that you have to get credentialed and you have to have state licensure in multiple states. For us here, of course, we have Ohio and Michigan because we're so close to the border. So we don't have anywhere else, but certainly telemedicine is growing and you could potentially think about that as an option. And then everybody's felt this pinch. We have sleep technician availability. That's been a really big issue for us as well, especially when we have a very large institution. All right, Dr. Shervin, I'm going to throw this one back to you. So Dr. Shervin published an article with a couple of other folks back in 2017, and I find this really helpful to kind of give this presentation some perspective, right? So 1978, 1991, there was an exam in PSG. Then from 1991 to 2006, there's a diplomat. I would venture to guess that there's probably some people that were maybe born in that time frame who are now fellows now, right? You're pretty close. So it wasn't that long ago that it was just the diplomat exam. And then, of course, there was definitely, I mean, everybody, I think, in this fellowship was probably alive from now to 2007 to present. But you then started with the biennial sleep medicine exam. And then only from 2011 to present really required fellowships to take board. So this is, you guys are in a newer field comparatively. And so you have to be mindful of that when you're coming into a new job. You know, not everybody is familiar with sleep fellowship, and you kind of sometimes have to explain and justify your role, but that's okay. And it's really easy to do so when you rattle off all of the issues that people can experience with their sleep. And often, you know, primary care doctors either don't have time or don't have as much background in sleep. And so it's great to have that as an adjunct, you know, resource for a lot of folks in the community. So it's easy to justify yourself when you know how new it is and how much growth we've had. The other thing, you know, to grow yourself as a clinician, it's incredibly important to keep up. So even an affiliation with a fellowship program like we have, you know, you get all the fun. It's like being the cool aunt. You don't have any of the paperwork to do, but all of the fun and certainly the enjoyment of working with fellows. The affiliation with medical schools, RN programs, and then even like an A-STEP program, or for those who are unfamiliar with that, that's the sleep technicians, their school that they go through. So you could be a medical director in an A-STEP program as well. All right. So final comments, and then I think I might have about 5 minutes for questions. But I will say that if you continue down your path as a clinician, as a provider, you have to find what, you know, fills your bucket. What do you love on a day-to-day basis? What play to your strengths, and then recognize your weaknesses. The things that are going to drain you are going to invariably sink you. So if you can find those people who enjoy doing those things, or maybe that's not, you know, doesn't bother them as much and they can help, that's incredibly important. And then also creating a culture of safety and productivity. I'm incredibly lucky that I swooped a couple of our U of M fellows, but they've been wonderful. We've been very lucky. Some grew up here, some, you know, are really, you know, tied to the area, and it's been incredibly helpful to have that amount of retention in our practice.
Wait a minute, just a couple?
Yes, just a couple, right? But we're incredibly lucky. And of course, like I've mentioned previously in this talk, we're kind of standing on the shoulders of giants. We are so lucky to have Dr. Shervin and Dr. Shalkar to have trained under, because we feel so confident in what we're doing, and we really appreciate all the support, which actually gets into my next slide. See, there you go. U of M, you know, we certainly fosters a confidence through exposure and a network of experts that are so close by. So we're incredibly appreciative for the collaborative nature we've had so far from graduation. All right, so that is truly it. My contact information is there, my number, my email. I'm happy to provide anything I can to try and help you guys start on to your new careers.
Thank you, Katie. That was fantastic. Katie, once people have a chance to jot down your contact info there, if you'd be willing to stop sharing, then and anyone who's able to safely turn on their cameras for the QA, that would be great.
Sure.
Oh, that was really helpful, Katie. Thank you so much. We spend so long in the ivory tower, you know, it's very helpful to hear reality and outside that, and I think very helpful for our fellows too, especially.
Sure, my pleasure.
Absolutely. Does anyone have any questions? I have some, but I want to make sure people get their questions answered. So I have a question. You described a lot of responsibilities and many hats that you wear in the course of your role. How do you make time for that continuous professional development, separate from box checking with MOC and things like that? But how do you incorporate that into your day-to-day routine?
Yeah, absolutely. That's a good question. So I do think I'm very lucky in that we have several people in our group that they just enjoy, reading, they do their sleep studies, and we are very collaborative in that I have a list to read from. If my list doesn't get done, and maybe I have, like today, I have this and like 4 other meetings, that they are more than willing to kind of help take some of those, but those are always reflected in their RVUs. And so we're very collaborative in that, but I'm well supported in ProMedica in terms of leadership. So my time is carved out. And I will say that's a live and learn thing. That is, like, you go to a point where you break and then you come back down and you say, I need more time in XYZ. And so I think if you get into a position where you have responsive leadership, it's really helpful to do so. But like I have clinic Monday, Tuesday, Thursday, half day Friday, and then all the other time is either, academic or reading time. And so I carve it out in terms of that. But yeah, it is something incredibly important. I'm sure you probably all feel that crunch at some point, but you have to be very specific with what your time and how to carve it out to help prevent that burnout.
Thanks, Katie.
I see a couple of those fellows in the reading room, like even with blurred, like Omar and Misha, I can see you are definitely in that fellow room. I believe I was in the corner, the left corner, if I'm not mistaken.
By the window.
Yes, by the window. You got it. Glad to see things haven't changed too much.
Which one was it? The cold one or the not cold one?
So I was pregnant for the entire time, so it was definitely the cold one because I was running hot like all the time. I think I had Grace. We were just talking before. My oldest is now 10, so I had Grace during fellowship, and then I was pregnant with my second one actually during fellowship too. So I was eternally pregnant during fellowship.
Katie, maybe I'll just briefly your comments on, I think you're doing all sleep, right? I'm sorry if I missed that, but, or no?
Yeah, so I split my time between sleep and pulmonary.
Okay. So do you have any words of wisdom on that, especially for our fellows? Like, does that make it more challenging or more challenging in a good way, or
yeah,
what's the intentions there?
That's a good question. So the only thing I would caution you with is that if you are looking to hire APPs, the current education for APPs or advanced practitioners is that they are instructed to see essentially one specialty or one thing per visit. So a lot of these APPs that are new grads are usually not as comfortable with seeing 2 things at once. And so that is a hard part about my practice, is that I'm the only one who often will see something very confident, like, hypoventilation with COPD, with PAP therapy. And so I would be careful with that. But it fills my bucket. I love the most complicated nitty-gritty folks, but then I build my clinic around that, and I have half an hour for those folks to spend the time and to really make sure that everything's taken care of. So it's a great question, but that's where I feel like I shine, is in those particular patients. But I would be careful in that you don't educate or like expect nurse practitioners or PAs to potentially follow in those footsteps.
Related question on that. When fellows are on interviews, often kind of hear different things in terms of how much time you get per new patient, per return patient, whether you get carved out time to read studies or expected to do that on your own time. I was wondering if you could speak to that.
Yeah, that's a good question. So for us, we have a little bit of a, I would say, a kind of integration period, if you will, for all of our new hires. And I would highly recommend you ask for this when you do start a new practice, and that when you're learning a new EMR potentially, or you're learning a new system, that you ask for, like, we have 30-minute visits for the first like depending on the speed for the first 2 to 3 months, because they're trying to get used to doing XYZ and then an hour for a new. Some folks, they want to get going and like they're ready to go and they just want to get busy and make those RVUs so that there's no question about, you know, earning their salary. But usually our practice now is 15 minutes for returns and 30 for news. I would say you just have to be very vocal and very quick to interact with leadership and just tell them like, hey, I'm looking to amp up, but I need some time to build XYZ because you guys don't have the templates and you don't have the, you know, dedicated diagnosis list. So it's going to take me some time to get to my RVU potential at that point. And then as far as cutout time for sleep, I would definitely, I mean, ultimately build in how you want it to be and how much you expect. Like for us, we have, each of us have a certain number of studies we have to read per month. And if we go beyond a certain number, some people have been successful in negotiating, you know, extra pay based on that, but not every place does that. So, and ultimately we're gonna have to try and figure it out because we're expanding. We just can't keep up to. So how do you pay everybody for their time and make sure they feel appreciated and certainly part of the group? That's a hard question, but certainly a good one.
Thank you, Katie.
Mm-hmm.
Anyone else have any questions? I don't see any other hands up, and I think you got some kudos in the chat. So
Oh yeah,
take a look at those. Yeah.
sure.
But thank you so much for sharing not only your time, but your expertise. I mean, you shared so much really important information with us. So thank you. And if you'd be willing to share any of your slides with the fellows, I'm sure they.
Yeah, absolutely. Yeah, definitely. I'm happy to help. And like I said, if you guys call, if you're going somewhere else or you're going here, you know, locally, I'm happy to help however I can to try and prepare, because that I feel like we've gotten so lucky with you guys helping us to prepare for what we're gonna see in the future, because it makes it a little less brutal when you're getting that much information that fast. So
awesome. Glad to hear it. Thank you again. That was fantastic, and hope
hey guys,
to see you soon.
take care.
Bye, Katie.